So I'll talk about unusual iris tumors. Are you seeing my slides? I'm Arun Singh from AIOS. So iris tumors are uniquely challenging. They're common, they're small, there are many types, and many patients are asymptomatic. So think about this, even in many kinds of tumors, then it's hard to know or for us to figure out the patterns of them because there's so many kinds. And if you look at the iris, obviously it's not one structure, many tissues, many layers. And I can tell you the tumors arise from each component of iris. So you can have tumors from melanocytic tumors, we are very familiar with those. You have stromal tumors, vascular tumors, muscle tumors, and of course tumors arising from the pigment epithelium. So think of iris as multiple layers, like you think of cornea. Always think of corneal dystrophy, epithelial dystrophy, stromal dystrophy, endothelial dystrophy. Same thing of iris. You can have tumors on all different layers. And we typically do history examination, those kind of things, but ultimately you have only 3 imaging tests we can do. We can do fluorescein, we can do UBM, we can do OCT. That's all you can do for an iris tumor. And we have clinics full of patients who have every test but no diagnosis. So that's why I always want to come back to the clinical photograph, because that's what's driving your diagnosis. You can do any test, but test doesn't tell you the diagnosis. Okay, so test only helps you. And in iris tumors, you have only 3 things that you can pretty much do. You can't do 7 tests. There's nothing else. And after that, you can only do 4 things to that patient. You can observe them, you can biopsy the tumor, you can do radiation, and if you think it's really something bad, you enucleate them. You have only 4 options. You have no 5th option of treating the iris tumor. And that's, of course, driven by your clinical diagnosis. So if you think it's benign, you may observe. If you think it's malignant, you will biopsy. And if you think it's like malignant and extensive, you think about something. So it's all driven from clinical diagnosis, basically. So you really have to come back to the clinical findings. So I'm going to go through 5, 10 quick cases in a few minutes, okay? So as a patient, you can see something in the angle. You can see it's coming from perhaps ciliary body and eroding the root of the iris. We can see that. So it's not really an iris tumor as such. We say this is an iridociliary tumor. And the moment you reach iridociliary tumors, we enter a whole different complexity. Just like you reach optic disc tumors and you don't know which layer it's arising from, the moment you cross iris and reach ciliary body, it gets a little bit more complicated. Because ciliary body is not visible. Only way you can assess ciliary body is through UBM. So if you don't do UBM, you don't know anything. So you did gonio, you think it's in ciliary in angle, or certainly root of ciliary body, and you did UBM, you can see that here, and you can get an idea that this tumor is trying to go outside its boundaries and entering the sclera. We can see that, right? You can get that? You can all see that here? What I'm pointing out right there. So that made me think that this could be some kind of an invasive tumor. It's whitish yellow. So we talked to the patient, and he wasn't very keen to come back many times. He said, just tell me what it is, and I can't keep coming back. No problem. I excised it. I like cutting. I excised it and come back as sarcoidosis. So this was sarcoid granuloma in a patient who has nothing else going on. No KPs, no iritis, no known sarcoidosis. So there you go. I said, no idea what it is. When you remove it, you figure it out. And that's the motto of this lecture. You don't know what it is. And there's another one here, very similar location, darker, of course. So we know it's melanocytic kind of tumor, nevus versus melanoma kind of discussion. But it's not iris. You can see it's coming from ciliary body. You can see that on gonio examination, correct? That's convincing enough. And you did UBM, you say, yeah, it's partly solid, partly cystic. So can this be melanocytoma, for example? Okay, that's the other differential. So in any way, I don't think I could do anything. You could sit on it, you can biopsy it, whatever. I excised it, and here it is. And this was actually a ciliary body nevus. So now you think about it, you say, I know about iris nevus and I know about choroidal nevus, but never heard of ciliary body nevus. Well, what makes you think the ciliary body nevus does not exist? Well, it exists. It's just that we can't see them. We can't diagnose them. We can't because we can't suspect them. But they are happening. So I saw 3 of them. Okay, I published them. But you'll only figure out if I cut them out. I don't think you should cut everything, but I'm just saying there is something called ciliary body nevus, and we should not be surprised by that entity. Well, look at this case here. I say, yeah, small roundish tumor, 18-year-old, 17-year-old young man. And on UBM, you can see stromal tumor, completely spheroidal, centered on the stroma of the iris. So you say, yeah, melanomas are stromal tumors. This is pigmented, is 17 years old. It could be nothing, just a nevus, go home. Except that I had seen him before, some years ago, and I had seen this photograph. So I said, this is a growing tumor, melanocytic tumor, in a young man, 17, 18 years old. So for me, growth in short period is significant. I excised it. And this is melanoma on pathology. Here it is, melanoma, no doubt about it, mixed cell type. And this is what he looks like after pupilloplasty. And look at this kind of brown tumor. It's sitting on the iris. It's not distorting the stroma. There are no vessels. There's nothing else. It seems to be just sitting there. And we know melanomas tend to be vascular, particularly on fluorescein. So you can do anterior segment fluorescein. We did that here for the iris. And it's totally dark. There's no vascularity. It seems to be disconnected with the underlying iris. We didn't have, this is before the time of anterior segment OCT. This is many years ago. We did a UBM, however, and you can see that it's sitting on the stroma. It's not centered like the other case, up and down. This is sitting on top of the stroma, and I could actually see the stroma right there. You say, this is the anterior stromal layer, and this is sitting like a ball on top of iris. That's the impression you get from looking at it. So we don't know exactly what it is, and so I excised it. I took a super sharp blade and found that plane. I just dissected right there. And you can see the dissection. Iridectomy was not done. We didn't think it was malignant. So we spared the sphincter, spared the stroma, and shaved it off just from there, that stroma. And it looks very nice postoperatively. And this is an iris varix, a rare kind of iris vascular tumor. You would never know if you didn't take it out. So there you go. Okay, so we don't know what it is. It's not melanoma. Take it out. But here we have somebody with a kind of a mass, fleshy mass in the angle. The eye is inflamed, pressure is up, neovascular glaucoma. He's an elderly man from a nursing home, no prior history. He has dementia. He does not remember anything. So what you say, it could be anything. But in terms of tumors, we would say it's more likely to be a metastasis, because metastasis causes inflammation. Metastasis can cause neovascular glaucoma. So we biopsied him with a needle aspiration biopsy, come back as renal carcinoma. And then go back and look in his history. He had a nephrectomy some years ago. He had forgotten. He had dementia. He doesn't remember. So it's a renal metastasis. So what can you do? Just to simplify, we put a plaque on it and give intracameral Avastin for neovascular glaucoma. 4 weeks later, he looked fine. Send him away. So you can get metastasis, eye is inflamed, and you can see neovascular glaucoma. But here's an kind of similar tumor, more kind of quiet eye. This is a 24-year-old man, goes for a contact lens fitting every year. And this time when he goes for contact lens check, they see this tumor. He has no symptoms of any kind, so no inflammation, no pain, no nothing. He's a college kid and comes home every summer and goes for the eye checkup. And so this is new onset tumor, recent onset, and you go look closely, you can see vessels in it. So that makes me think of melanoma. When I see this kind of uveal vessels, it makes me think of uveal melanoma. So you say, oh, this could be melanoma. Eye is quiet, he's 24 years old, but you can see fine vessels in it. So I did not want to do needle biopsy here because highly vascular tumor, I thought I'll get bad hyphema. So I just wanted to excise it. I excised it, and this he looked like it was melanoma. So I just showed you totally translucent melanoma. Okay? Not FNAB, totally excised, completely confirmed. And he looked fine. And here's another translucent mass, also very, very vascular. Much more vascular, a different kind of vessels than the other vascular tumor that I just showed you. And it is on fluorescein lights up, not surprising. So again, I don't want to do needle biopsy here because we'll get bad hyphema and may not be enough cells. So you have negative biopsy and a big hyphema, not a good outcome. So I told him we could excise it because we don't know what it is. Anybody has a guess as to what this may be? I didn't know what it was. I said, it could be melanoma. Always think melanoma. Anyway, was excised. Was a leiomyoma. So why vascular? Well, it's arising from the smooth muscles of the iris vessels. So iris vessels have arterioles, and arterioles have muscle, and it's arising from that muscle. And because it's arising from the muscle of the vessel, it's vascular. But it's not a vascular tumor by itself. It was excised, and we have a beautiful case. Anyways, so I showed you this patient with a sarcoidosis. So in the summary, I've shown you tumors of all kinds, and think of all layers. I didn't have a chance to show you some iris tumors, and most of it has come from the book that's been recently published. You can read more about it. Thank you so much. Any questions, any comments? Yes, Honda. Bhavna, you also speak something. Rita, you also speak something. Jonat, you also speak something. Everybody is learned here in the room. Okay, go ahead.
Very nice cases. And so I'd like to have a broad question regarding the choice between fine needle aspiration biopsy versus excisional biopsy. So I always worry about hyphema when I consider fine needle aspiration, but for a larger excisional biopsy, I also have other concerns. So it's always a bit tricky to mess around the anterior segment.
Yeah, you don't want. That's why the patients are asymptomatic. They have 20/20 vision, so that's a challenge.
Yeah.
So the golden rule is as follows: if you think it's melanoma, clinically, then do FNAB. If you think it's not melanoma, do excision. You could be wrong in the end, doesn't matter. But if your clinical impression is melanoma, you do needle biopsy, you can put a plaque. If you think it's not melanoma, excise it.
So plaque is immediately following aspiration biopsy?
Yeah, within few days.
For the cytology.
Yeah, cytology will take about 2 or 3 days. In one day in our center, or the next day we have the answer. So you can wait 4 or 5 days for the eye to settle down a little bit and just do the plaque.
Okay, so for one case that's sitting on top of the epithelium, that case, how do you pull the tumor out?
How did I? Okay, I didn't have time to show the surgical technique. We used what's called small incision guided hydroaspiration. So think about the DMEC cannula. Okay, so you make a paracentesis incision or keratomic incision, 3.2 millimeters roughly. Put a viscoelastic in the anterior chamber, take DMEC cannula, connect it with a 14 French catheter to a Helon cannula, make everything viscoelastic. And after you loosen the tumor in the anterior chamber, you aspirate into the cannula, and then you withdraw the cannula. So it's a guarded hydroaspiration. Okay?
Thank you so much.
It's more about this technique, but I didn't talk about it. That's why you get beautiful outcome, because you have a very small incision. You have 3 millimeter incision. You did not make a 8 millimeter condylar incision. Yeah.
Thank you so much.
Yes, sir. Yes, donate.
Thank you, Professor Singh. That was very impressive. I have 2 questions. The first one, Honda just addressed it. The second question is, when do you perform the pupilloplasty? And when do you decide not to do the sphincterotomy? And when do you decide to do it?
Yeah. Well, if it's a stromal tumor, you have to cut the stroma. And if it's melanocytic tumor, we stay away from excision, so we'll do FNABs. Because if it's beyond certain size, you cannot do pupilloplasty. I do pupilloplasty at the time of surgery. But if you have bad hyphema or somehow you're not able to do it, it's okay to come back another time. Okay, for example, we had a patient one time, we did the sector iridectomy, did not know what it was, and there was really bad hyphema, total hyphema. As much anti-tamponated aspirin, I did whatever I could. I could not clear the hyphema. So I just stopped. And I told the patient, we'll see, control the hyphema, we'll come back later and do it. And afterwards, she said she was fine. She was not bothered by the sector iridectomy. She was wearing a contact lens, and there was no need to do pupilloplasty. So you can stage it. If patient is pseudophakic, it's easier to do pupilloplasty. You put the needle through the tenoprolene suture. But patient is phakic and young, then you can have a little difficulty. So you could stage it if you are having any difficulty about making your mind up about it. Okay.
Thank you.
Vishal.
Thank you for the interesting cases. So one question is about the melanoma of iris, what you showed. So how is your surveillance protocol, particularly for the metastasis? Because from the choroidal compartment, we know how to kind of follow up these patients. Now, the iris or even the ciliary body and the melanoma, because we know ciliary body, the vascularity and the metastasis might already have gone. So, is there changes your surveillance protocol to look for metastasis in this group of patients?
So we follow the same protocol for all uveal melanomas, whether it's iris, ciliary body, or choroid. We know iris melanomas, chance of metastasis from 0 to 1%. Pure iris melanomas, and ciliary body is like uveal melanoma, so choroidal melanoma, so you don't go there. Talking about pure iris melanomas, I have about 150 cases in my clinic. We have 0 patient with that metastasis. But that's, you can say, yeah, you're not going to get metastasis, but you have no real proof of it. There are cases in the literature, some patients getting iris melanoma with metastasis. So the moment you say it's a uveal melanoma, we do the minimum. And minimum for us is ultrasound of the liver every 6 months. That's about it. So basic baseline, we'll just do this. And that's what we offer. After 5 years, you can stop it if you like. But I wouldn't do nothing, because you have a clinical diagnosis of melanoma, and so you are kind of forced to do some kind of surveillance. In any primary tumor, you have to do some kind of surveillance. So there's no exception. So you say it's good news, it's not going to happen, we're not worried about it, but you should do it. Okay. Bhavna, you look very thoughtful.
Yeah, no, very impressive cases and really very nice. I was just wondering, what do you do if the FNAC is negative? Like,
okay.
we tried FNAC in a few cases, turns out to be negative, and we still
So
have
that's the biggest problem in FNAB,
Yeah.
FNAC, same thing. And the problem is really not in the surgical technique or with the surgeon, except how you're handling the sample and who's reading it on the other side. So first of all, we don't do dry smears, okay? So that's totally bad. It's all liquid-based cytology. So you take the needle, you rinse it into cytolite, is what we normally use, spin it down, etc., right? So liquid-based cytology is going to give you a very high chance of positivity. So that's number one. And number two, I would say, is the cytologist. So if you don't have a good cytologist, then your cytology will be negative. So that's all it is. So we can say we have 95% plus in our own data. We have clinically interpretable biopsy report for iris tumor. So I tell the patient, there's 5% chance. I will not be able to figure out what it is from the biopsy. And if that is the case, I'll go with my clinical impression. And if I think it's melanoma, and that's why I'm doing the biopsy, I'll treat it. But like anything else, I like to have a confirmation. I have 95% chance I will get a confirmation. But if you cannot confirm, then it will default to your clinical judgment. Yeah. You can't say, because FNAB cannot exclude malignancy when it's negative. Yeah, it could be sampling error, technical error, whatever error. Yeah. Very good question. Rita from Indonesia, Jakarta. Is you having jet lag? Yeah. Okay. You want to say something? Introduce yourself. Tell me where you're from. We have a few more minutes for the lady. Yeah. Okay. Carry.
Ruju Unadkat. I am from Center for Sight. I did my fellowship with Dr. Santosh Unawar, sir. And my question to you is, in case of melanoma, where we have done excision biopsy and it apparently shows that margins are negative, would you still do secondary plaque for those cases, or you would like to keep them for observation and manage them conservatively?
So iris melanoma with resection, negative margins, what should be done after that? If it's negative margin, we would say we will not do secondary plaque, okay? And we know still with negative margins, you can still get recurrences. And we say in our series that recurrence is approximately 3%. So there could be histologic issues in interpretation. Iris samples are very small. They sometimes get folded. When they're processing, the pathologist is not able to clearly tell the margins. But if they say the margins are negative, then we tell our patients the very low chance of recurrence, we will not do a plaque. If margin is positive, then you have to do a plaque. You have incompletely resected tumor, you have to treat it. But if a margin is negative, we don't do plaque. For us, that's surgical excision.
Thank you, sir.
Yeah? Okay. Yes, sir.
Mudit Tyagi. I work in LVPI in Hyderabad. So me and Vishal actually usually share a lot of cases between us. So both of us sometimes get stuck and have this dilemma. How do you differentiate some of these melanomas from granulomas? Any clues in imaging which can help us in differentiating on terms of ICG or FFA? How do melanomas sometimes they get confounded? We have had some cases which we thought were amelanotic melanomas turned out to be granulomas, and vice versa.
So you're talking about iris, you're talking about ciliary body, you're talking about choroid.
Choroidal.
So you're talking about choroidal granuloma versus choroidal melanomas?
Yeah. Amelanotic choroidal melanomas to be precise.
Okay. So I'm glad you specified that, because when it's pigmented tumor, you have a very narrow differential.
Yeah.
If it's pigmented, it's nevus melanoma, melanocytoma, or hemorrhage, or some kind of metastasis from cutaneous or mucosal melanoma. So, or B dump. So you have very narrow differential if it's pigmented. If it's not pigmented, it could be one of 1,000 things. Okay? So this is very important. I'm going to say it's not pigmented. Even then you have 4 or 5 colors you have to choose. Is it white? Is it yellow? Is it orange? Things of that nature. If you say if it's yellow, I think of metastasis or granuloma. If it's more like orange, we say it's hemangioma or some unique kind of metastasis, say renal met or carcinoid met, something very narrow, or thyroid, for example. And if it's white, then you say this could be inflammatory granuloma or some healed process. So things of that nature. So you're looking for associated findings. So if there's inflammation, there may be some retinitis, there may be some vasculitis, there may be some papillitis, there may be some vitritis. So looking for those findings. And of course, onset, is it painful? If there's some kind of arthritis in the front, ancillary findings, patient has rheumatoid arthritis or not, things of that nature. So that kind of thing. Because for me, in my practice, fortunately, it's all been filtered, okay? Various patients go to various clinic, and I come to, they've been filtered through many layers, and I only get to see tumor-like things. Once in a while would be inflammation. So the commonest inflammation that I see in my clinic would be scleritis. That can look like a met, by the way. Multifocal, yellow-white kind of ill-defined lesions with some detachment and some congestion. You say, oh, is it a met? Is it this? So to me, scleritis comes most. We don't see TB like things in my clinic in the US so much.
Thank you.
Yeah. Okay. So we have some more time. Okay. I didn't bring my computer. We can talk about something else. What else you want to talk about? So you give 12 minutes, 4 speakers, that's 48 minutes. What about the rest of the time? Engage the audience. What do you want to talk about? I didn't bring it along, but we can download it if you like. So just we talk about I can just explain to you what we are talking about. So in normal surgical techniques, of sector iridectomy or sector iridocyclectomy, classic iridocyclectomy, you're making a long, a big incision, 6-8 millimeters at the limbus, okay, for the iridectomy, and further back for iridocyclectomy, okay. If it's a mid-stromal tumor, pupil is okay, angle is okay, and you say, I need to excise it, why do you have to make 6 millimeter, 8 millimeter incision, just like you would do in olden days, extracapsular surgery? But you think about laparoscopic approach, you say, I can make multiple small incisions in the cornea and enter the anterior chamber that way. So if the tumor is at 6, you make an incision at 12. And with vitrectomy scissors, the long ones, you can make radial incisions along the tumor after deepening the AC and the posterior chamber, and using angulated scissors to cut the base. So you cut out the whole sector like a pizza slice and float it into anterior chamber. So they're small incisions, okay? So multiple small incisions. So you can make 5 incisions in the cornea, each one is 2 to 3 millimeters, nothing will happen as long as they are not connected with each other. We know that, okay? So you have done all that, come any angle you want, think of laparoscopic surgery, and you're working in the anterior chamber. If the patient is pseudophakic, it's better. If they're phakic, you can still manage with using a lot of viscoelastic. So once you have isolated the tumor with clear margins visibly, about a millimeter outside, then you inflate the anterior chamber and make one of the incisions slightly larger to 3.2 millimeter keratome, and use DMEC cannula, which you have connected to the Helon syringe with 14 French catheter that's been cut. So you have a viscoelastic chamber, and the anterior chamber is full of viscoelastic. Then you have the cannula full of viscoelastic. Then you have the whole syringe full of viscoelastic. At the moment you connect the two, the whole thing becomes one system. And then you aspirate it, and this piece of pizza slice floats into the tube. It folds like a taco. And once you've done that, you cleanly remove the tube out. So you have not disseminated the cells to the wound. You have not kind of distorted the iris, because iris is fragile. The moment you hold it, it will shred. So you do not touch it. And then you do the pupiloplasty if you can, and then put 1 or 2 sutures to the bigger wound, and that's all there is to it. And once you have the syringe out, you take a filter paper and express the syringe onto the filter paper. The whole thing comes out, and it flattens out, and you send it in formalin. So you did not touch the margins. You can have very good interpretation of the margins, and that's called small incision, guarded hydroaspiration surgery. Yeah, it's published in BJO. You can look that up, and technique also on mine. Okay. So the iris, I have to say, does not bleed. So if you have prominent feeder vessels that you might in some of the tumors, you can do endocautery. So same cautery that they use in the vitrectomy surgery, you can cauterize the feeder vessels, and you can cut, when you cut radial cuts, nothing will bleed. It will bleed only towards the angle. Just increase the pressure a little bit, and it will stop. Bleeding is not generally a problem, but if there is, for whatever reason, if you went too far down into the ciliary body while making the basal incision, then it's going to bleed. You tamponade, wait, put air, sit for a little bit, and if you can't clean it, just put a suture and just come out, and you go back later. But I have to say that's very unusual. There's one case out of like 100. But you will see such cases. So I tell the patients 2 problems of surgery. Number 1, hyphema. Number 2, hypotony, if there's wound leak, etc. But that's very uncommon now with this kind of thing. You only will get secondary ocular hypertension because you did not remove the viscoelastic completely, because the patient is phakic. So I use old-time Simcoe cannula to take out the viscoelastic. So that may be left behind. So give them some oral Damox, and that's fine. So that, for me, because we can excise them safely with small incisions, we have turned more and more towards excision, because I can do it safely. And margins are negative, we have good interpretations, and we are fine.